Hello dear colleagues, friends and followers. Welcome to the AHA 2019 wrap-up by the Thoraxcenter for Radcliffe Cardiology. My name is Nicolas Van Mieghem and next to me my good friend and colleague Joost Daemen. This AHA meeting in Philadelphia truly was a good one with several intriguing study results that we will summarize here. Arguably the most anticipated trial was ischemia. So Joost, what were the most salient takeaways?
Yeah, so ischemia was definitely one of the blockbusters of the meeting and one of the long-awaited trials. So in brief, the trial enrolled 8,000 patients in over 300 sites and was designed to finally settle the question as to whether for patients with stable angina and moderate to severe ischemia, an invasive strategy, so that means angiography plus or minus PCI or surgery, would result in a reduction of hard clinical endpoints like death and myocardial infarction. So, in brief, the study was negative, meaning that there was no difference in between the optimal medical therapy arm alone versus OMT plus an invasive strategy in the primary endpoint, which was a combined endpoint of death, MI, or repeat hospitalization for either unstable angina or out-of-hospital cardiac arrest. So with that, you could conclude that there is no more room for PCI in patients with stable angina and moderate to severe ischemia in terms of hard clinical endpoints. However, I think several comments should be made about this trial. At first, the trial included a highly selected patient population. So if you do some simple math, a lot of sites enrolled less than one patient per month. 1 out of 4 patients in the quality of life subset analysis had no angina at all at baseline. 29% of the patients didn't even have either progressive angina or worsening angina over the last few weeks. So I think that explains the highly selected cohort, because a lot of patients obviously didn't want to participate in this trial because they were at least randomized in a study in which there was a likelihood of 50% that they would end up without the therapy that we have been advocating for the last 50 years that relieves angina. Nevertheless, another interesting thing was that the event curves crossed at 2 years, and this was mainly driven by the occurrence of myocardial infarction. In the invasive treatment arm, obviously there was a risk of periprocedural MI. But at the longer run, the risk of spontaneous MIs that occurred up to 4 years, so the duration of the study was significantly less, 30% lower in the patients in the invasive arm as compared to the optimal medical therapy arm alone. So that is food for thought. Furthermore, was there nothing positive about the study? Well, I think yes, because there was also a subgroup, or let's say a predefined sub-analysis presented on quality of life, presented by John Spertus. And he clearly demonstrated that quality of life and angina classification significantly improved in patients in the arm with the invasive treatment strategy. So to me, this trial demonstrates that PCI works in its primary goal of namely relieving angina, is safe, does not result in an additional risk of death and MI as compared to OMT alone. So with that said, I think we have an additional trial that answered a very important question. PCI is something that relieves angina, but is also something that in patients with stable anginal complaints without, let's say, left main disease, can be withheld for some time. So there's no need to rush to the cath lab immediately in those patients. However, you could argue if this is something that is a reasonable approach for younger patients with severe signs of angina.
Yeah, a different approach or perspective is that a PCI for this indication also does not come with an outcome penalty.
Exactly.
So you will probably or arguably improve the quality of life of those patients. And don't forget, 30% of the patients in the control arm eventually underwent a PCI.
Yes,
so I think it is, we're now in 2019, the era of shared decision making. You have to inform your patient and then together come to a conclusion whether to proceed with a watchful waiting and optimal medical therapy or a more invasive strategy with also less tablets during the following. GALILEO was highly anticipated because the trial had been prematurely stopped 1 year ago because of an excess of death or a first thromboembolic event, also an excess of all-cause death and more primary bleedings in a treatment arm with rivaroxaban and NOAC, 10 milligrams in patients who did not have an indication for all anticoagulant drugs after TAVI. So the problem with rivaroxaban with this rivaroxaban trial was that in the treatment arm, patients had the combination of aspirin on top of rivaroxaban, whereas the control arm had DAPT for 3 months. And then after 3 months in the rivaroxaban arm, the antiplatelet drug aspirin was stopped. In the control arm, the clopidogrel was stopped. And then, so patients continued either with rivaroxaban or with aspirin. I think that I was not so surprised by the findings that there were more bleedings. Of course, we were all surprised that there was a death penalty. But still, I think it's safe to say now that in patients who undergo TAVI, there is no reason to add non-vitamin K oral anticoagulant drugs unless there is an indication for it.
Exactly.
So if a patient has atrial fibrillation, that's a different scenario. And as a matter of fact, as we alluded to that in our preview, we are studying that in the envisaged TAVI-AF trial, where patients with an indication for oral anticoagulant therapy are randomized to either vitamin K or edoxaban after
monotherapy.
Yes, monotherapy. So highly interesting, but maybe no longer very relevant, was the GALILEO 4D analysis. That was a predefined analysis, including the patients with a CT scan follow-up at 3 months. A total of 231 patients were included in this analysis, and reduced leaflet motion appeared in 11% in the DAPT arm versus only 2% in the patients on rivaroxaban. Leaflet thickening occurred 3 times more often in the DAPT arm, so 32% versus 12%. There was no difference in the echo parameters, with similar gradients in both treatment arms, although patients with impaired leaflet motion had a marginally higher gradient and lower valve area. So I would conclude that the issue of leaflet thickening and dysmobility is not clinically relevant, and that there is no need to actively screen our TAVI patients for leaflet issues by MECT. Another trial that had a lot of attention was Recovery. Recovery was a Korean study that ended up being a relatively small study, including only 145 patients. Patients were young, only mean age of 64, with low operative risk, Euroscore 2 less than 1%. A mean maximum velocity was 5.1 meter per second. More than 50% had bicuspid aortic stenosis. The median follow-up was more than 6 years. Results were compelling. The trial was highly positive in favor of early surgical valve replacement in asymptomatic aortic stenosis. In the control arm, 3/4 eventually underwent surgical valve replacement, which was urgent in 17%. The primary endpoint of operative of cardiovascular death was reached in 15% of the control arm, quite high, versus only 1.4% in the surgical arm. So a highly significant difference, and a number needed to treat of 20 to prevent 1 event at 4 years. I believe the surgery in general and valve disease literature in particular is maturing, with more and more randomized trials underpinning our practice, and I'm sure that asymptomatic low operative risk patients benefit from an early intervention. I'm not sure whether that intervention should be surgery. It could also be TAVI, and this is of course the subject of early TAVR, which will enroll more than 1,000 patients to a watchful waiting approach or a TAVI. And interesting in that particular study is that all the patients will undergo exercise testing, because in order to know that the patient is truly asymptomatic, you want to know that while exercising you're not able to reveal symptoms, or if a patient does not manage to increase blood pressure during exercise, that's also already an indication for valve replacement. So I think early TAVR definitely is going to be a worthy follow-up to Recovery. But what do you think? Will Recovery change our practice?
Well, I think not that much, but what I found interesting in this trial is that we are talking here not about severe, but about very severe AS, and that is something that we've been discussing over the past week. What is the cutoff for very severe versus severe? I mean, there are a lot of patients in this study which had the average gradient was 5.1 meters per second. While we see a lot of patients with gradients of 4, 4.5, with an AVA of 0.99 or maybe 1 or 1.01. You know, these variability in these echo measurements. These are the patients that are, I guess, more often asymptomatic, and whether these should be also, whether these patients would also benefit from this early treatment strategy, I'm not sure. And that's something we don't know yet based on the results on these trials, which looked a bit deeper in the very severe category. So that to me is still something that will need to be clarified in the future.
Okay, Let's talk about TWILIGHT.
So TWILIGHT, so several interesting pharma trials at the AHA as usual. One of the first ones we would like to highlight is the predefined subgroup analysis of also one of the blockbusters of ESC, the TWILIGHT study. So in brief, TWILIGHT enrolled 9,000 patients and randomized them either to ticagrelor monotherapy or ticagrelor plus aspirin for a period of 1 month. After high-risk PCI, so the trial only enrolled high-risk patients, so high risk for both either ischemic event and bleeding, and only randomized patients 3 months after the PCI, meaning that if they were event-free within the first 3 months, patients were randomized to either ticagrelor monotherapy or dual antiplatelet therapy with aspirin.
For a year.
For 1 year after the randomization.
Yeah.
So interestingly is that, as we know, ticagrelor has a label for ACS, but in this study 1 out of 4 patients were also treated with stable angina. So that was the reason that Usman Babar presented the predefined subgroup analysis on ACS patients. So in this trial, just unstable and non-STEMIs, so no STEMIs were allowed in this study. And what he presented is that the key results of the main findings were virtually replicated. So there was a decrease in the primary endpoint with the ticagrelor monotherapy group with over 50%. So the risk of BARC type 2, 3 or 5 bleeding halved in the patients on the monotherapy with ticagrelor, while there was no price at all in terms of the risk for ischemic endpoints. Event curve virtually overlapped. So very interesting results as expected, because we knew already from the heterogeneity plot from the main findings that there was no sign for a difference in the treatment effect between the ACS and non-ACS patients. More interesting to me is what the take-up of these results will be in routine practice. So we know, at least for now, that if you see somebody after 3 or 4 months after the PCI in which there have been no events, and the patient complains about bleeding or other types of hematomas, bruises, that it's very safe to stop the aspirin in these patients. On the flip side, people are arguing already that we should be more provocative, more proactive in calling back these patients after 3 months to see if they were event-free and actively pursuing them to stop the aspirin. I'm not sure that's the way to go yet, but it will definitely be a topic of debate in the near future.
I think it would be great to finally drop the aspirin at an earlier stage. I think this is the future, and it's becoming more and more evident from studies like Global Leaders and now also TWILIGHT that probably the more potent new antiplatelet drugs are the way to go.
Are good enough as monotherapy. Yeah. So the second trial that was presented and also anticipated in our preview was the COLCHICINE-PCI trial. So the COLCHICINE-PCI trial was a randomized controlled trial, blinded, single center, which actually built it on the hypothesis and the knowledge we recently gained that colchicine has unique anti-inflammatory properties, proved to decrease MACE rates in several subgroups of patients with cardiovascular disease, and as just published in Cold in the New England, is in the post-MI setting related or linked to a significant reduction in heart clinical endpoints. So this study specifically looked at the potential of colchicine as given as a single dose pre-PCI, looking at its ability to reduce per-procedural damage as assessed by cardiac biomarkers and inflammatory markers as hsCRP and interleukin-6 beta. And this trial was, from that perspective, somewhat neutral, so no difference in the endpoint of ischemia and per-procedural biomarkers. However, there was a significant change in the change in interleukin-6 and hsCRP in patients with treated with colchicine as compared to placebo. So I'm not sure yet how to interpret these findings in real world. I mean, there were ACS patients in this trial, so that makes already the adjudication of per-procedural enzyme leakage very complex. That is one. And second, the value of items like interleukin-6 and hsCRP to me still have to be defined. So I think future work has to be done here.
But does contrast somewhat with the COLCHICINE trial, right? Which was a positive study in terms of clinical endpoints, but it was a different scheme, of course.
Exactly, and so that was not, this trial was a single GIF, while COLCHICINE was long-term therapy, completely different patient population, different perspective. So I think the trials are complementary, but for the elective PCI setting and for the per-procedural effect, I think we need some more data.
Yeah.
Second study that we would like to highlight, or the third actually, is the DAPA-HF trial. So as alluded to also in the preview, DAPA-HF was the big heart failure study with dapagliflozin. So the SGLT2 drug that was introduced as an anti-diabetic drug actually, but proved to have unique properties in terms of its potency and potentially reducing hospitalizations for heart failure. So that was the DAPA-HF. So DAPA-HF randomized almost 5,000 patients, if I'm correct, to either dapagliflozin or placebo in patients with heart failure and reduced ejection fraction, irrespective of the presence of diabetes. So what we learned from this trial is that the drug resulted in a significant decrease in the primary endpoint of cardiovascular death or repeat hospitalization for heart failure in both patients with diabetes and non-diabetic patients. So again, here at the AHA, a predefined subgroup analysis of this trial, focusing more on the potential differences in the treatment effect between patients with or without diabetes. That was quite interesting because what the investigators showed is that the risk for events in diabetic patients was as expected higher, but the treatment effect was virtually identical in both diabetics and non-diabetics. So with rates of event reduction of 25 and 27%, the effect of the drug was really similar irrespective of the presence of diabetes. Moreover, when looking at the impact of HbA1c levels at baseline, there was also no difference in treatment effect. So the trial was just as effective in patients who had well-controlled diabetics as compared to those who had diabetics with very high HbA1c levels, although obviously at the end of the spectrum there were less patients. But very reassuring, and I'm pretty sure that this drug will find its role in the new heart failure guidelines that are on its way, irrespective of the presence of diabetes in these patients.
Yeah, so eventually the challenge will become to keep our patients, our heart failure patients, on this regimen of all kind of drugs that they need to take according to the current literature. Right?
I agree.
Okay, we have also some data on Impella use in the USA that was presented, and that shed a more sobering picture on the impact and appropriate use of this technology in United States cath labs. One conclusion stemming from a retrospective analysis including almost 50,000 Impella patients in high-risk PCI from 432 hospitals in the premier healthcare database suggested only higher costs and no clear clinical advantage with Impella. Another registry from the National Cardiovascular Data Registry dataset looked into STEMI and cardiogenic shock and compared almost 2,000 Impella patients with more than 80,000 balloon pump patients. Finally identified 3,360 propensity matched patients, so balloon pump versus Impella. Impella was associated again with worse outcomes and more bleeding. So I believe both studies represented difficult analyses as it could not ascertain the indications for Impella, and there will be reasons why a center would have selected Impella over balloon pump. So there is definitely confounding bias, but in my opinion it only urges for a more controlled use of these devices and to selected centers with proper expertise and skill set. I'm not sure whether, for instance, 400 centers in the United States have to offer Impella care. This kind of technology would benefit from centralization, so what these studies illustrate, in my opinion, is that Impella use in less experienced centers will result in worst outcome and comes at the price of bleedings. So what do you think about Impella? For everyone, in every center, or selected?
It will definitely not be for everyone. In my opinion, there's no need to have it in all the sites. So with that, I'm with you. Regarding the results of these trials, I would be very cautious. I mean, as you mentioned already, I mean, this is retrospective analysis. Huge selection bias cannot be excluded and will have impacted the outcome. So that is one. Second thing, what I can only say is that I think the pump has its value, at least to my personal opinion, but there is, and these data just underscore that there is a lack of dedicated prospective data in different categories, being either shock, being either high-risk PCI. with this, the uptake will be hampered somewhat, at least from a scientific perspective. So I think the company needs to take its responsibility in being more aggressive with these future prospective data.
Mm-hmm. Yeah, so this wraps up our coverage of the large cardiology meetings of 2019. So thank you, Joost, Rakesh, Rob and Mark of the EMC audiovisual team and our friends at Radcliffe Cardiology. We hoped you liked these Thoraxcenter perspectives and that you will keep following us as we head into 2020. Let's meet again soon.
Thank you. Bye-bye.